All to the center today for discussion of human, animal, and ecosystem health, bringing some worlds, some disciplines, some actors, some tools together that don't always come together in the room. And I think in part because we're having the meeting, you can tell that we think that this discussion is a useful one, a necessary one, and a productive one. And so we're quite pleased to have three experts and practitioners here today to share their experiences with us so we can have a rich discussion on this complex and interlinked topic. Let me say just a quick word about where you're sitting. The Woodrow Wilson Center is the formal memorial to President Wilson. As our only president who had a PhD, Congress in 1968 decided to set up a living memorial where the worlds of research and scholarship can come together with the worlds of practice and policy so that they can learn from one another, reflective of what we're trying to do here today. The Environmental Change and Security Program is a 14-year-old program trying to, again, bring those worlds of scholarship and practice together with a special focus on issues of environment, health, population, development, foreign policy, and even at times security policy. So we're hitting a lot of those bases today, and so we're quite pleased that we have the diversity of topics and the diversity of people in the room to tackle these. I'm going to be very brief in terms of the introductions. You will have hopefully picked up both a participants list and a longer bio statement for each of our speakers. Deana Clifford is Associate Wildlife Veterinarian at the University of California, Davis, the School of Veterinary Medicine's Wildlife Health Center. And she's project coordinator for the Health for Animals and Livelihood Improvement Project in Tanzania. So we're very much looking forward to hearing about her experiences in that specific project. Gladys Kalema-Zikusoka is founder and CEO of Conservation Through Public Health, a Ugandan NGO with an office at Colgate. Gladys is someone who is now twice in a month. It's wonderful that she's been here speaking at the center, someone that we've been very privileged to get to know in a range of conferences focusing on these links between population, health, and environment. So it's terrific to welcome her here to the center again, as I said, second time in 1 month. And so Gladys is going to talk about her experiences in Uganda and share those insights. I should also say it's been quite a month for Gladys for a number of reasons, one of which is she just received the Zoological Society of San Diego's 2008 award for conservation in action. Really very high honor and something that she should be commended for. Working with the mountain gorillas, it's really tremendous. And so, again, Gladys, we're so thrilled you're here. And Steve Osofsky is someone who's been a longtime supporter and participant in events here at the Wilson Center. It's terrific to have Steve here. He's developed and now manages Animal Health for Environment and Development, the AHEAD program at the Wildlife Conservation Society, WCS, and it's one of their fundamental parts of the WCS One World, One Health initiative. And Steve has been very helpful in talking to a number of us here at the center and really this community of folks in town that are looking at links between population health and environment and human health, and helping those of us who don't know particularly as much about the animal health side understand these linkages. And so it's terrific that Steve's able to join us today. Just a final word that we're webcasting the event live. Those of you who are watching on the webcast know that the PowerPoint slides are online, and so I'd suggest it'd be much easier for you to download and follow them there than try to see them on the screen on the television. When we do come to the Q&A time, my colleagues will bring around a microphone, and so for those of us in the room, if you could use that, tell us who you are, where you're coming from, and pose your question to the mic, then the folks online can hear it as well. So I think we're going to start with Steve, in fact, almost reverse order, and Steve to kick us off. So please turn the floor over to you.
Well, thank you all very much for making the time this afternoon. I'm going to run through a series of case studies from Africa to highlight and illustrate what we call the One Health approach and its value as an entry point for facilitating both conservation and development. Basically, all the things I'm going to discuss in the next 15 or 20 minutes are about this relationship between human health, wildlife health, domestic animal health, and environmental health and stewardship. And a lot of the examples I'm going to give you are related to the AHEAD, the Animal Health for the Environment Development Program, and a lot of them are executed by collaborating partners in other organizations. But I've chosen them to illustrate different ways to basically take advantage of these relationships to achieve conservation and development goals. Well, this is an iconic image for me. This is a dead wildebeest along a foot and mouth disease fence in Botswana. And this goes back to my time in the early 1990s as Botswana's first wildlife veterinarian. And I need to go back a few decades to explain to you why this happens. Back in the late 1950s and early 1960s, colonial governments and donors were looking at ways to give southern African countries some economic traction. And to make a long story short, I understand the context of that time period. They were thinking fairly monosectorally, and they focused on the creation of export markets for beef so that southern African countries could get beef to Europe, largely, to the EEC at the time. The reason that they had to put up fences is in order to get beef to Europe, it had to be disease-free. And there's a virus called foot and mouth disease that's carried by wildlife, specifically by the African buffalo. Buffalo don't get sick from this virus, but they carry it and they can spread it to cattle. So the consequence was that thousands of miles of these fences were put up across the SADC region in order to facilitate these export opportunities. And because of those fences over the subsequent decades, hundreds of thousands of wildlife died, and many species. Well, let's fast forward a bit. That's just the background. Let's look at southern Africa today, where I think there's some exciting news for those of us interested in conservation and its economic potential. The circles on this map are trans-frontier conservation areas, and very simply, many of you who've been to the region have been to many of the national parks contained within those circles. Southern African leaders have been looking for, what is their comparative advantage economically, and many of them have come to the conclusion that sub-Saharan Africa still leads the world in opportunities related to nature in terms of tourism, in terms of consumptive uses like trophy hunting. And so in order to maximize those opportunities, Southern Africa right now is really leading the world in a very bold experiment. You've probably heard the term peace parks. These trans-frontier, these trans-boundary projects are linking protected areas like national parks, usually across international boundaries, and essentially making wildlife the preferred land use of choice. I'd like to say that this is all being done to drive conservation of biodiversity. Really, the fundamental driver is economic. If you look at SADC, the Southern African Development Community, from a GDP point of view, tourism, consumptive uses like hunting that I mentioned, those nature-based activities now exceed the contribution to GDP of forestry, fisheries, and agriculture combined. That's astounding. So in that context, this trans-frontier conservation area is really, this concept is getting a lot of traction. I should mention, if you add up all the different TFCAs, and that's the abbreviation I'll use, you get about 120 million hectares of land, potentially focusing on wildlife as the primary land use. That's the size of New York, California, and Texas combined, to give you an idea of the scale that I'm talking about. Well, the first place I want to take you to is what's called the Great Limpopo Trans-Frontier Conservation Area. That was one of the circles on this map. And I'm going to run through this as an example. It's sort of a microcosm of some of the challenges we face in these different TFCAs. Remember, I was telling you that they put up a lot of fences back in the 50s, 60s, and since. Well, in order to foster these peace parks, we're really talking about rezoning, taking fences down. What does that mean? Well, the Great Limpopo is where South Africa, Zimbabwe, and Mozambique come together. Many of you, I'm sure, have heard of Kruger National Park. And this circle represents about 100,000 square kilometers. That's about the size of the state of Virginia. It's vast. Now, I don't want you to misinterpret this and think this is about turning this whole area into one giant national park. That's not what this is about. This is a complex land use matrix. This area has villages, roads, railroads, irrigation, all the things you think about. But again, the vision is to reconnect the protected areas in South Africa, Zimbabwe, and Mozambique, and again, making wildlife what I describe as economically rational and socioculturally acceptable land use choice. Okay? Well, if we're going to do that, we have some issues, and I'm going to run through a few examples of where the disease issues are important, and I don't want to frighten you. When I'm in the region working with my colleagues, I always am working on the premise that what we're trying to do is highlight these issues to be proactive, not to destroy this vision, but to recognize its complexity. So the first disease I want to talk to you about is called bovine tuberculosis, very closely related to human tuberculosis. This is an alien invasive species, if you will. It doesn't belong here. It was introduced to South Africa about 150 or 200 years ago by European cattle. Well, again, to make a long story short, bovine TB was discovered right here in Kruger National Park's Buffalo in 1990. And since that time, it's been found to move from south to north throughout the whole park and has spilled over into a whole range of other species, such as kudu, cheetah, lion, baboon. It's quite a problem. I also need to explain that bovine TB is a lot like human TB in that it's a zoonotic disease, meaning it can move from animals into people and make people sick as well. So remember, we're talking about connections, about building corridors. And if we want to reconnect Kruger, for example, to Ghana-Rougeau in Zimbabwe, one of the potential routes is through this area called Sengwe. This is the Sengwe corridor. There are thousands of people and thousands of cattle living here, and preliminary research to date indicates that there's no bovine TB in the cattle. Believe it or not, before Zimbabwe's recent political implosion, they had a very strong veterinary services, and they've had BTB under control. Okay, and what we know right now, it's still early days, but we don't think that there's BTB in the wildlife of Ghana-Rougeau. So if we reconnect this area this way, and the wildlife of Kruger bring BTB in, that's got a few ramifications. And let's take a step back and look at this cross-sectorally now. Another piece of the puzzle is that the people of Sengwe have among the highest HIV/AIDS prevalences in the region, so they're often immunosuppressed. They also have very poor meat hygiene and they don't boil their milk. So they're very susceptible to the main routes of transmission for BTB. So the message here is if we're going to do this, we can't let a conservation initiative cause negative consequences for the agriculture and livestock sector and the public health sector. The net loss would be negative, it would be a net loss. And as a conservationist, I want this vision to succeed, but we have to look at these cross-sectoral impacts. So let's look at another disease. Let's look at rabies. Rabies is a big problem on the Mozambique side. When you have rabies, it's often due to uncontrolled feral dogs, and the victims are often children. And that's the case here. Interestingly, those of you who know Kruger know it's the best studied park in Africa. There had never been a case of rabies in Kruger until December '06, and it was traced back genetically to a domestic dog strain from Zimbabwe. Again, with the current chaos, dog vaccination has slacked off in Zimbabwe, and so rabies spilled into Kruger. Well, if we're going to reconnect this area, take down fences, and potentially let rabies into an ecosystem like Kruger that historically has never had it, that could wreak ecological havoc. Okay, so that's another thing we have to be proactive about. I'm going to give you a few more examples. Up here we have Nagana, sleeping sickness of cattle, carried by tsetse flies, a vector. How we reconnect this conservation area, how we create this corridor is very important. If we create habitat that facilitates the movements of a vector like the tsetse fly, and Nagana, sleeping sickness, trypanosomiasis, comes back here, huge implications. South Africa hasn't had Nagana since 1903, and they don't want it back. This part of South Africa near Kruger is full of cattle, very important part of the economy. And interestingly, those of you who know the history of white rhinos know that there were less than a few hundred in the late 1800s, early 1900s. South Africa saved the white rhino from extinction. Kruger is now home to the largest population of white rhinos on the planet. White rhinos are actually fairly susceptible to Nagana, to trypanosomiasis. So we don't want Nagana coming back this way. So if we're going to reconnect, we have to be sensitive about the vector issue. And if we take, again, that step back and look at this macroeconomically, remember we were talking about foot and mouth disease at the beginning. There's a strain of foot and mouth up here that if we reconnect this landscape and don't take the proper precautions, and the buffalo bring that strain of foot and mouth into the larger landscape, that could impact South Africa's exports for beef, multi-million-dollar annual impact. So again, all these issues, and these are just some sort of nice examples of potential cross-sectoral impacts between a conservation initiative, livestock agriculture, and public health, that if we don't deal with them proactively, this vision, which has real potential for the region, could fall away. So that's what I call the landscape level entry point for health and conservation. I'm just going to diagrammatically run through sort of the main issues I just talked about. We talked about sort of the zoonotic diseases like BTB, like rabies, that animals and people do share, and then diseases of economic importance that aren't zoonotic, like foot and mouth. foot and mouth doesn't affect people, but it affects their livelihoods. And if we can think about this, we're talking about the impacts on the animal production side, domestic animals, and impacts on the livelihoods of farmers. And as a conservationist, I'm talking about the impacts on the wildlife production side. That's what I want. My job is to make wildlife the land use of choice. We essentially want to make more of species that are endangered. And again, whether that's successful feeds back on tourism, hunting, the economic drivers of conservation. At the center of this, and what relates directly to local, national, and regional economic outcomes, are the disease control strategies we choose. If we don't think cross-sectorally and we just throw up fences, that can devastate a particular sector like wildlife. If we use a pesticide and don't do our homework in terms of environmental impact assessments, if we create water catchments that contribute to malaria, there's all kinds of impacts of different types of strategies. And the point is to try and get the balance here right and focus on the outcomes of the strategies we're going to choose through, using sensible scenarios planning. Well, I want to take you to another part of the region to give you another example of how health impacts conservation. I'm now taking you to Namibia. And this is what I call the animal health policy entry point. I want you to pay attention to the colored areas. The green areas are state protected areas. This is Etosha here. And the colored areas are what are called conservancies. And they are mostly adjacent to protected areas for good reason. This is all semi-arid Kalahari. This is very, very dry land. This is all, what you picture when you think about, pretty much a desert area. Conservancies have a very interesting history. I'm going to define what they are for you. The history of this region under colonial times is that wildlife didn't belong to the people. It was the king's game. It was the state owned all wildlife. And when you have a situation like that, as I'm sure most of you are aware, you often end up with a tragedy of the commons situation. Wildlife was exploited, hunted out. It was a resource that no one could claim ownership to. Well, Namibia really led the region and very smartly, about 15 years ago, changed the legislation to give conservancies tenure rights. Conservancies are places where communities now have not only the rights to live where they are, but they have the rights to manage and utilize the wildlife resources on their land. This was a watershed legislative event in the Namibian government, and it was very, very smart. And what it's done is given people an opportunity to make very sensible economic decisions. Again, this is semi-arid area. Wildlife is much more productive than livestock. When people were given tenure rights, they put wildlife in these conservancies. And so now you have species like gemsbok and sable and buffalo reproducing extraordinarily well, and this has been largely funded by USAID over the past decade plus. You have wildlife production augmenting greatly, economic opportunities abounding. But let's talk about the animal health policy issue. Right here is what's called the red line in Namibia. Going back to our friend foot and mouth disease, if you're in a conservancy north of this red line, you're not allowed to export live wildlife out of your region. In the greater SADC area, live game is very valuable. People are constantly restocking game farms, both public and private, for tourism and other uses. And this potential right now is bottled up in the conservancies. So we've been working with colleagues in Namibia about trying to tweak this policy. When this red line was put in place, you had a zero risk tolerance for largely white farmers protecting livestock. The Ministry of Agriculture is very heavily subsidized. Now that we've got a conservancy movement where poor black Namibians are starting to benefit, there's an opportunity to tweak this policy without really risking foot and mouth spread to white holdings, but facilitating the export of live game, and I think creating a tipping point for the ultimate sustainability of conservancies. Again, my job, make wildlife socioculturally acceptable, economically rational land use choice. If we get the foot and mouth disease policy right, the export markets blossom, and these conservancies will be around for a long time. So that's the animal health policy entry point. I'm going to very quickly talk to you about another entry point, which I call the public health entry point. And I'm not going to steal any of Gladys's thunder. This is actually a slide I borrowed from her a few years ago, and she's going to talk in much more detail. But when we talk about great apes, we have a very special situation where we share 140 or so pathogens with chimps and gorillas, for example. And this is the trinational area where the Democratic Republic of Congo, Uganda, and Rwanda come together. Basically, we have the last few hundred mountain gorillas, and they're living in a sea of people. Because we're all great apes, essentially, we have to take some special actions when we're talking about conservation here. We have to do all the normal things we do. Anti-poaching, making sure that there's education, making sure that people living around these protected areas share the revenues that these protected areas bring in. But in addition, we have to make sure there's good public health. And when I give this talk when Gladys isn't in the room, I talk about her work as an example of using conservation, and I just love the name conservation through public health. It's great, because that's what this is all about. This isn't about saying to the people, we're going to worry about your health because we really care about gorillas. No, this is a reciprocal relationship, and the fact is, in using Rwanda as an example, in some years, gorilla tourism is the #1 earner of foreign exchange in Rwanda. And so the people want health, we all do, and they want to keep the gorillas healthy. So that's why public health is such an important entry point in a landscape like this when we're talking about great apes. I'll let Gladys cover that more. I will say that just recently there was a study on chimps in the Ivory Coast, and it related also to Gombe, where it was pretty clear that the #1 cause of mortality were respiratory viruses, almost certainly traced back to researchers and local people. So it's almost killing them with kindness by visiting them if we don't take the right precautions. Okay, so moving on from the public health entry point, I want to talk to you about what I call the community-based animal health entry point. What do I mean by that? This is an example from Kenya. And this chapter is from a book that we did a few years ago on these issues. That's one of the flyers I gave you. And it's very interesting. Most of the places we work as conservationists in the world, we have conflict between people and particularly carnivores. People who keep livestock often lose them to lions, leopards, hyenas, whatever it may be. Well, a group of veterinarians went into several sites in Kenya and looked at what was really impacting livestock mortality. And when you have a lion print next to the remains of your cow, you're pretty angry. But when you're looking through a veterinary lens and you realize that the impacts of disease are orders of magnitude higher in terms of livestock productivity, it gives you another opportunity to change the balance. What these veterinarians found was that these local people, some of them were Maasai, were very well aware of the presence of disease. They've grown up with it. But it was sort of background noise because they didn't have any way to intervene. But by training people to implement very simple animal health programs using relatively inexpensive interventions and doing it on a cost recovery basis, all of a sudden livestock, meat, milk, even chickens and egg production can go way up. If you combine that with awareness raising and education, you can actually raise people's thresholds of tolerance for living with carnivores. That's not me, is it? And so by using community-based animal health, teaching barefoot vets, if you will, in different communities, people's food security improves. And at the same time, they can be more tolerant of the occasional losses by lions once they understand that their net productivity is actually much higher than it was before the intervention. So that's in a very simplistic way what I call the community-based animal health entry point. Well, related to that is what I call the food security entry point. And for those of you who work in conservation, if you haven't recognized the linkages to food security, this is a very, very important issue. COMACO stands for Community Markets for Conservation. It's a project we have in Zambia. And it's really I'll try and describe it as simply as I can. It's essentially creating a farmers cooperative in parts of Zambia. It takes out the middleman and gives producing farmers better prices for their commodities, both crops and livestock. And at the same time that people's food security is improved, there are conditionalities attached where if you want to participate in this cooperative, you have to agree not to poach. You turn in your guns, you turn in your snares. Well, one of the things we've done here is we've worked with a group called the International Rural Poultry Cooperative to do something very simple. We've been vaccinating chickens, again, using community-based tools like I described previously, with a very inexpensive vaccine, again, on a cost recovery basis, vaccinating chickens for a disease, a virus called Newcastle's. This is a devastating virus. It comes through a couple times a year and it can wipe out all your chickens. But when you control it with this vaccine, all of a sudden, very interesting social phenomena develop. First of all, women in these villages control the chickens. They suddenly have cash. They can pay school fees. If there's a few eggs each week that the kids get, that has huge benefits in terms of growth and cognitive development. So there's all kinds of obvious nutritional and social benefits of something as simple as vaccinating chickens. But again, because COMACO is an integrated program, people are at the same time, now that their protein needs are being better met by domestic animals, there are fewer incentives for them to poach. And they're starting to take advantage of the rebounding wildlife populations and are actually diversifying their income portfolios, if you will. They're building bush camps and starting to have tourists come to the areas that were depleted of wildlife, but the wildlife's now rebounding because we've displaced their protein demands. I'm not at all trying to imply this is automatic. This takes a very concerted effort and a partnership between the project and the people. In fact, the people now own the Farmers Cooperative COMACO. So it's a very interesting model, but it's the food security entry point that we're using to facilitate, again, both conservation and development. I'd be remiss if I didn't describe what I call the classic wildlife health entry point. We've had the landscape level entry point in the Limpopo. We've had the animal health policy entry point in Namibia. We've had the public health issues in Central Africa. We've had food security and community-based health. This is wildlife health. This is the bread and butter of what WCS started doing several decades ago. And this is the Global Avian Influenza Network for Surveillance, or GAINS. And this is based on something we've always done, which is get good data on diseases of wildlife. But until recently, nobody cared about that data except us, wildlife conservationists, particularly those with interest in disease. But since things like SARS and avian influenza, all of a sudden, we have new partners in the public health arena. This program is largely funded by USAID and CDC. You can see a lot of the other partners as well. All of a sudden, there's a recognized synergy between the wildlife health community, the public health community, and those interested in agro-biosecurity and agricultural trade. And so all of a sudden, wildlife health has a new relevance. And again, we're using our wildlife health tools as a constituency builder. So people who didn't really care about what we did before now have a direct incentive, and they're collaborating with us because here's an issue that's of relevance to us as conservationists, and it's relevant to these other sectors. So that's what I call sort of the wildlife health entry point. A lot of what I've run through very quickly, we work pretty hard to make it available and put it in the public domain. I often give talks to my colleagues, but it's more important for me to give presentations and put things on the website for people who aren't in the veterinary business, because our most successful programs are those that involve partnerships with sectors that we didn't used to interact with. So there's a lot of material on our website, a number of books. I've given out the flyer. One of the chapters that I gave out is from a new book called State of the Wild 2008-2009. It's on these issues. It's really important for us to get the public to understand this so that they're supportive of integration. If you think about in our own country, the relationships between USDA and the Department of Interior and CDC, those are not easy relationships, and those of you in government know this. But the types of issues I've talked about are starting to force, if you will, really important partnerships. So just to conclude, this is the Kavango-Zambezi, the Kaza Transfrontier Conservation Area. This is where 5 countries in southern Africa come together: Namibia, Angola, Zimbabwe, Zambia, and Botswana. When this comes to pass, this will be the largest connected conservation area on the planet. The reality is it's a long way from happening. If you travel in this area, what you come across as you move around are fences. Fences because of the foot and mouth disease virus that I told you about before, but also because of another disease called lung disease, contagious bovine pleural pneumonia, which is a disease of cattle. It doesn't even affect wildlife, but people have chosen fencing to control that disease as well. And what's been interesting for me is to meet with my colleagues in conservation who aren't from a health background and have them recognize for the first time, perhaps, that if they don't deal with the veterinary issues, if they don't deal with animal health and its economic implications, any vision for connectivity is just an illusion. So the realities in a place like Southern Africa are that if we don't foster these cross-sectoral partnerships and look at the trade-offs proactively, ultimately as conservationists we lose. We might have a short-term victory, but that's not what I'm after. So if CASA is going to work, it's going to require the types of intersectoral collaboration that I've been describing. Otherwise, these fences, they'll never come down. I think that's where I'm going to stop, and we can save other discussion for the Q&A, I think. Thanks.
Good afternoon, everybody. I'm going to follow on from what Dr. Steve Osofsky has given a very great introduction about all these issues, disease issues at the human-wildlife livestock interface. And my presentation is going to focus much more on what we're doing with the great apes in Uganda. I'm here too with someone else from our organization, Conservation Through Public Health, Gladys, who's founder and director of ICT for Development, and more importantly, my husband. And in this outline, I'm going to briefly talk about why we started CTPH, to focus directly on these particular issues, how it fits in with the AHEAD program that Dr. Steve Osofsky has just been talking about, and an overview of our 3 integrated programs, some of the challenges we're facing, and some of our future plans. We started CTPH because we realized that in order to manage protected areas, it was very important to also look at the disease issues. Some of the poorest people live in and around protected areas, and they have very little health care and information on diseases that can spread between themselves and the wildlife. And this same slide has come up, Steve put it up, but one of the main reasons why we started CTPH is because we had a scabies skin disease outbreak in gorillas, which was traced to people living around this national park. Now, scabies is normally a disease which wouldn't necessarily kill somebody, but it resulted in the death of an infant. The rest of the group got very, very sick, and especially the younger ones. We had to treat them with ivermectin antiparasitic for them to get better. I'm actually there with Dr. Richard Koch, who was heading the Kenya Wildlife Service at the time, and he had seen this very same disease in cheetahs in Masai Mara. But I think they felt that in cheetahs it was due to a lot of tourists coming close to the cheetahs. Now, this actually resulted in the death of the infant, and we began to think, well, by the time a gorilla dies of scabies, it must come from a closely related host. And we did also find out that people around that area have a lot of scabies. It's a common disease in low-income groups of people in Africa. And this typical situation around Bwindi is that people basically live very, very far from health centers. Imagine when someone falls sick and you have to carry them on a stretcher up this steep hill all the way to the health center. You only take them if they have a disease that's about to kill them. And so very often by the time they get to the health centers, it's too late for the doctors to do anything. So something like scabies, it's like, that's not something you go to the doctor for. It's not worth hiking up this steep hill. And here's a gorilla group in called Nkuringo Gorilla Group. We tracked this group here. We came out of the forest into someone's banana plantation. And this is a very typical situation in Bwindi. I think when Heather went to Bwindi, she saw the gorillas eating bananas in someone's garden. They actually tracked them there. So she realized that we were telling the truth. So it's a pretty common situation, and these very people don't really benefit. They just see human-gorilla, they really face a human-gorilla conflict. Also, when the gorillas come into the gardens, they destroy their crops, and then they're not able to, it affects their livelihoods. Sometimes they may not be able to pay school fees for their children to go to school just because gorillas are destroying the crops. And yet gorillas are more likely to come out of the park because they're now habituated and they're used to people. So all these issues lead the gorillas to be more and more affected by disease from people. So during that time, when we investigated this disease, I was the vet officer for Uganda Wildlife Authority, and everybody asked me to set up these workshops, education workshops, which were focusing on health issues between people and gorillas. And at the time that we went out, everyone thought that the community would think that we cared more about animals than people. And it was a very interesting time because it was a few months after tourists had been killed when Interahamwe rebels came into Uganda in 1999. And when we went out, there had been a big slump in tourism. So when we went to 8 villages and we spoke to all the people there and we asked them, do you think gorillas are important? They said yes. And we asked them, why do you think gorillas are important? And they said, because they bring tourists who give us money. I said, do you love gorillas? Yes. And they really felt it because now they weren't getting tourists coming in and they were not getting as much income. But another thing that we found is that those who benefited from tourism were very willing to listen to what we had to say, and those that didn't even lied that they had never seen gorillas, because we went all the way to Congo, where this particular group of gorillas had been. And we spoke to them about these disease issues in the local language, because most of these people can't read or write in the local language. We talked about TB, scabies, measles, polio, Ebola, and intestinal parasites. We didn't tell them that diseases can only come from people to gorillas. We said it can also be the other way around, especially regarding Ebola. And the diseases on the right are ones that have been proven or suspected to have spread between people and wildlife. Whereas the ones on the left were very common in the community, quite common, but had not really been known to spread between people and gorillas. And it was very simple graphic information. If you need to defecate in the forest, dig a hole 30 centimeters deep, the gorillas can, have access to it, even in your own garden, because many of these people don't have proper pit latrines, if at all. And so their children just shit in the garden. And they don't dispose of their rubbish properly. They don't cover their, they don't wash their clothes regularly. And we believe they got scabies because many of them only bathe once a week when they're going to church on Sunday. They don't have access to safe water, and they don't wash their clothes regularly. They wash their clothes maybe once a month. So we came up with all these issues in the brochure, and they came up with these recommendations to bring health and diagnostic services closer, which was the responsibility of Ministry of Health, to strengthen the Human Gorilla Conflict Team, which is a group of community volunteers trained by Uganda Wildlife Authority to chase gorillas back to the park. We've strongly felt that it should be the community to do it so that they're empowered. And it brings a greater understanding between the relationship between the community and the park. They also asked for compensation for crop damage, but the Uganda law doesn't allow it. So we couldn't do much about it at the time. And personal hygiene, they wanted to have proper pit latrines, cover their rubbish heaps, and more health education. And we felt that it was their responsibility. Gorilla tourism, I guess, has transformed the community of Bwindi. Before gorilla tourism came along, their only livelihood option other than digging was the tea factory. So a school like this one, the Bwindi Orphan School, was built because of tourism dollars. Tourists pay like $25 for kids to go to school every term, and it's really made a difference to their lives. Gorilla tourism has also brought gorillas much closer to people. This is a gorilla group that's always ranging close to the park. And this is Mwirima, the silverback in the group. And these are two rangers who, we were in the advanced team waiting for tourists to come. This is a gravity water scheme that was built with funding from International Gorilla Conservation Program to improve on the issue of having access to water in the park. And IGCP is a coalition funded by AWF, WWF, and FFI. But the gorillas even like to range near here. And they also come close to the army, because ever since the tourists were killed, we now have army right in the park, to protect the tourists. So they leave rubbish lying around, and the gorillas like to range here. So the disease risks are not only high when they're high up in the mountains, but also right at the park headquarters. So some of the lessons that we learned was that the communities were, not only were they happy because of the gorilla tourism, and they're willing to listen to what we had to say, but we went as a multidisciplinary team. And we also went there with the sub-county health assistants, who are the people who always talk to them about health and hygiene. And that made a big difference. However, some people whose crops were destroyed during this time were not so happy about the gorillas. We also conducted some TB research with a Charlotte Fellow Award from AWF, and when I was at NC State and working at the zoo, and we found 25% of chronic coughers had TB, and 5% of park staff were positive with acid-fast sputum tests. 2 people died during the research because they didn't complete treatment, and that really affected me. And the reason why is there wasn't a program called Community-Based Direct Observation of Treatment in Bwindi, but it was available in Queen Elizabeth, where you watch your next door neighbor watches you taking medicine every day for 8 months to make sure that you finish it. And these are all the situations that led us to starting CTPH. And these are some of the GPS readings we took during the research. And CTPH is a non-profit. We started off here because we started it when I was completing my residency in NC State. My supervisors allowed me to spend time, and I got a certificate in non-profit management from Duke University. And we got NGO status in Uganda. I'm glad to see that a resident is here, Ted Mashima, NC State resident. The Queen of Buganda is our patron, and we have staff, board of directors, and volunteers from many places. And what we feel that around protected areas, conservation and public health is interdependent, and if we work on it together, we're more likely to be most cost-effective in controlling disease, which also affects agriculture and culture. And because of this, we became an ahead collaborator in the Great Apes Working Group. In 2003, there was we were part of a conference in Durban for IUCN, and I think this is really when the whole AHEAD program was launched. And our mission is to promote conservation and public health by improving primary health care to people and animals in and around protected areas in Africa, with a vision of preventing and controlling disease transmission where people, wildlife, and their animals meet, while cultivating a winning attitude to conservation and public health in local communities. We have 3 integrated programs: wildlife health monitoring, human public health, and information, education, and communication. When I was here 2 weeks ago, I focused more on the human public health, and this time around I'll speak more about the 3 programs. With wildlife health, we've partnered with Uganda Wildlife Authority, and their park staff collect fecal samples every week from the habituated gorilla groups, which we then share with the 2 hospitals that work closely with us. And if you get to Buhoma, those of you who've been there, Bwindi's tourist site, you see this sign as you drive towards the park. And over here we have the food clinic for gorillas and other animals, and we also have a telecenter, which Lawrence helped to set up. And you have internet in the bush. And in the wildlife health monitoring program, not only the park staff collect weekly fecal samples, but we have the human-gorilla conflict team collecting samples whenever gorillas are outside the park, which is a very important time to collect samples from them because that's when they're most likely to pick up diseases from community members. Also, we were fortunate that we were able to collect samples during the recent gorilla census in 2006, because then we were able to look at samples from gorillas that are not visited by people, and were able to get some comparisons. And we were first funded by WCS Food Vet Program to carry out the ranger training, and then later on US Fish and Wildlife Service, and then later on MacArthur Foundation. And with this, we've been able to train 170 park staff and 90 Hugo members in gorilla health monitoring. We've also had vets from Mountain Gorilla Vet Project joining us in this training, which was good, Dr. Mike Cranford and his group. And during this training, we basically trained them to collect samples from night nests, and then also how to identify gorillas so that they can be able to monitor their health. We analyzed the samples at the lab. We've had help from Cornell, who've given us some equipment. And this is one of the wardens. He's heading monitoring and research. He also comes and gets involved in the analysis. He's very interested. And some of the things that we're finding are that the gorillas are at risk from diseases like amoebic dysentery, which is very prevalent in the communities. And obviously, because it's a disease also of poor hygiene, it's not surprising. Gorillas are also at risk from diseased goats, which are grazing at the park periphery. There's one time we went to track the gorillas, and there was goat dung next to gorilla dung. We took a sample of the goat dung, and it was full of parasites. So, of course, the animals are not dewormed at all. And the Nkuringo gorilla group, we also found that spent most time outside the park, in people's gardens, showed trends of having a higher parasite burden and a range of parasites. The Nkuringo group spends over 50% time outside the park, and they're in the other site that's being developed for tourism. Tourism has just started there. We're very fortunate to have US Ambassador to Uganda, Steve Browning, and his wife Susan visit the gorilla clinic in 2006. And this is because we've received some funding from USAID through the Prime West program in Uganda. And he also got to look under the microscope, and he got to see some worms. So he was very excited. We got him to do some work in the park. Then in the Human Public Health Program, we mainly carry out grassroots community education campaigns, focusing more on good hygiene and zoonosis, and how it links to gorilla health, ecotourism, and sustainable livelihoods. We are also strengthening community-based healthcare in villages around Bwindi. And they find that community-based healthcare is the way to go in rural areas because, as you see, people live so far away from health centers. And if you can get the community to now take ownership over their health, it's more sustainable. I think the Ministry of Health, we've got a lot of support from Ministry of Health, especially the head of the National TB and Leprosy Program, because when I went to his office and said, we want to start this program, he was very excited because he said, you know, we've thrown so much money, you know, there's been so much health money thrown to solve health issues in Uganda, but the health issues are still there. And he believes it's because the communities are not owning the programs. They just think it's a government program. And he felt that NGOs had a very strong role in getting communities to own the program. The government couldn't do it, but NGOs could. So he was very excited. And in the community education campaigns, we've used various methods, drama workshops, brochures. We've started radio programs, and IGCP helped to fund this at the beginning. And we're also coordinating a public health and conservation technical support unit, which is made up of the local governments where the wildlife is found, and the Uganda Wildlife Authority, and supporting NGOs. We also got funding from Irish government to continue this, and later on USAID, Prime West, AWF. And in the drama workshops, we don't go out and act ourselves, but we locate local drama groups and give them those brochures that I showed you earlier, and they act a very good message, which is very educative. We've managed to reach over 7,000 people through these drama groups, including children, which is great. And we've also set up some health message signposts around the park, both in English and the local language, Ruchiga. And in community-based healthcare, we've had to set up an MOU with Kanungu to give us permission to do this work. And what our staff do is that they go and follow up on these patients once a week, once every 2 weeks, to see how they're taking the medicine. And we take samples to the health centers, to the government health center, and patients to the missionary hospital. The missionary hospital doesn't want to get samples, and the health center doesn't want to see patients. So it works out really well. And we're able to follow up on these patients every 2 weeks through our nurse aide goes and follows up on them. We also work with the traditional healers, who are very important healthcare provider in this community, and actually their homes are now recognized as health center ones, because most people go there before they go to the modern health center, because they're much more accessible and they have more time for you. So we've teamed up with theta, traditional and modern health practitioners together against HIV, who link the traditional healers with the modern healers in order to treat the symptomatic infections of HIV and any other diseases. And in engaging them in these discussions, we can get them to admit that they can't treat TB and HIV. And once they refer a TB suspect patient, they can become their community volunteer. It's also a very good chance for them to chat with to be able to link up with the community conservation rangers and the health assistants, because we always have the workshops together with them. And they often say that they want to collect medicinal plants in the forest, and they're not able to collect them because UWA doesn't allow them to go into the forest. And Wildlife Authority then has to explain that there are only certain sections of the park where you can go into the park and collect medicinal plants, because some of it is for tourism, some of it is for research, and some of it is for multi-use like that. So it's a chance for them to also get to talk to them about these issues. We've so far had 52 people enrolled in the CB DOTS program. That's Gashima, nurse aide, very dedicated. He's from the community, interviewing patients. And as we interview them, we also ask them, how often do you see gorillas? So over time, we're collecting data on the linkages and how much interaction these people have with gorillas. We started the Population Health Environment Initiative in 2007, and we found that this program greatly strengthened the public health programs that we're doing already, because many of these people have very many children, and because of that, they can't keep them healthy. And it's one of the first, it was the first USAID PH initiative in Uganda, and it involved us recruiting for community reproductive health workers. They're all volunteers, and the community chooses them. It's a very transparent process. And we also got 22 couple peer educators, one from each village. And in the first 9 months, we had a very great response, where we had over 1,500 homes visited. Because what these volunteers do is they go and visit the homes and talk to people about TB, scabies, HIV, and family planning. And we insisted that at least a third of the homes they visit should be homes that border the park, where people often see gorillas. Because these are the homes that don't get to benefit from the integrated conservation and development initiatives. Just because when you call for a village meeting, the person's so busy far away from the village chasing animals back to the park that they can't even think of going to a meeting. And so after 10 years of ICDs in Bwindi, which was considered one of the most successful areas for community conservation in the world, they did find that the people who needed to benefit most didn't benefit. And people were thinking, what's the point of ICDs? But I really think ICDs are important, and if we're able to reach these people through home visits, then we can have better outcomes. We've also had 140 new family planning acceptors in a community where there are many myths and misconceptions about family planning, and people are highly people are not educated, and so anything, any little thing can make them scared. Like if you start to focus on the side effects, they get scared and say, I'm not going to try that. So I think these people have done very well. And these volunteers want to form a CBO for sustainability. This success led to further funding from USAID, and this is a quarterly meeting with all the community health volunteers, and Dr. Lynn Gaffikin, who got funded by John Snow International, has really helped to make it a very well-run program, and very well, we're able to collect a lot of useful data. We've also incorporated scabies and HIV onto the TB and family planning model. And with scabies, the focus is good hygiene, and with HIV, the focus is to educate people to go for testing. We don't have testing centers, obviously, but there's one area that now has a testing center, the NGO Missionary Hospital. And to make the situation even better, the CRUISE and CPEs, because they visit people's homes, have been able to refer over 480 people for TB testing. So all the programs are very well integrated. But before I go into the challenges, I'm just going to present a flip chart that we've now developed for the community health volunteers to go out to the communities when they're carrying out education. And they're actually training them to use it this week in Bwindi. This is a family of 8 people bordering the park. Let's say Mr. and Mrs. Mugisha. And Mrs. Mugisha is pregnant with her 9th child. And the rest of the kids, only half of them can go to school. As you can see, they all have torn clothing because they're very poor, and some of them have skin diseases. When they sit down to eat the meal, they're all fighting over the food because it's not enough. And the father, of course, is having his full meal and he doesn't really care about everyone else. And then they need some food, so they go into the forest to hunt, which is illegal. It's actually poaching. And the children also go and collect fruit in the forest, which is illegal. And so Mrs. Mugisha is really fed up, and she asks her husband, let's start thinking about family planning. And he's not interested. Because people believe that the more children you have, the wealthier you are, even if you can't look after them. And then the gorillas come into their garden, the children chase them away, and the mother is actually relieved that they haven't gone to school so that they can chase away the gorillas. And then the father goes to the bar, which is his normal routine. And he comes back when he's drunk and threatens to chase his wife away from home. And of course, everybody's very upset. 10 years later, 2 of the children have died. And they're their graves. And the eldest son has 2 wives who are staying at home with them. And they have children, and he's left them because he's fed up. So this is a family that is really suffering because of having too many children. And then the positive family, when they were young, they planned how many children are we going to have. And they went ahead and had 4 children, who happened to be 2 boys and 2 girls. And all the 4 children go to school. And they sit down and they have inside the house to have a meal, and it's very well organized. And they help each other with the family cause that they have to do. When the gorillas come outside the park, this is the main difference in the reaction. Because these people are educated, the children are educated, they understand the benefits of the park to the community. So they call out the human-gorilla conflict team, as opposed to chasing away the gorillas themselves. And the conflict team, of course, is much more effective in chasing the gorillas back. And a few years later, the son has become a park ranger, and the sister's graduating today, and she's going to become a nurse at the local health center. So with this, they sit down and have a discussion with in the home that they visited, and the various questions that we've designed for them to ask, and get them to understand why it's important to have fewer children. So some of the challenges we've had in the public health program have been convincing health partners that the CTPH is actually complementing their efforts and not duplicating efforts, because actually what we do is we get more people to their health centers through the community volunteer network. And we've had limited resources to continue the programs in one parish that wasn't bordering the park, because the funding from the Irish government was health money, and they didn't mind where we were, whereas the funding from USAID was biodiversity money, so that we had to be in a parish that borders the park. We also find that the supporting health centers have limited resources. And because Uganda is one of the worst countries affected by TB, among the 22 worst, we get free TB treatment and we get free TB reagents to analyze the samples. But sometimes these resources don't get to the health centers, and it becomes a challenge when our nurse aide brings in sputum samples. People are also alcoholics, as you saw in the flip chart, which prevents people adhering to daily TB medication. But our treatment success is, we've been able to achieve quite a great treatment success. We've started radio programs where people come and give testimonies on how they got better. And it's actually resulted in many more people reporting to be tested for TB, including Hugo members. And also family planning clients come on with their husbands and say, now, after I've had 9 children, I'm on an implant and I'm very happy. And that has attracted people to go for family planning. And then we've also, Lawrence initiated this project of community websites, and these are in the local language. I guess the first community websites in the local language in Uganda. And with these, both in Bwindi and Queen Elizabeth, where we have our other program, the youth are more involved in conservation. They're able to access information which is relevant to them. We try and cache information which is relevant to the situation around their park. Then this leads us to the final program, which I'll go through very quickly. Our telecenter, which is at the board of the park and enables the community to get involved in technology and open up to the outside, gain access to information from the outside world, as well as learn about conservation and public health issues. With this telecenter, we have several partners from the private sector who have been able to help us, and including the Uganda Telecom Limited, who gave us a free satellite dish. This is our son Indigo, before he was 1 year old. He's been very much involved in setting up CTPH. And we've had over 150 members graduating, and over 40% are women. And this is very important because we are part of a Makerere University Gender and Technology Outreach Program where they encourage women to get involved in computer education, and we make sure that many of them are women. We've also had over 3,000 community members accessing it, and they're using it much more than the tourists, and they're actually paying for it. So it's one of the, in fact, the only sustainable program we have at the moment. And the reason why we made them pay from the very beginning is when UCC, Uganda Communications Commission, gave us funding, which they got from World Bank. They only gave us, 40% of what we needed. And they gave some telecenters 100%. They gave us 40%. And they found that the telecenters that they gave 100% ended after the funding ended, and the ones that they gave 40% or 60% have continued afterwards. And all they gave us was money for computers, so that from the very beginning we had to charge people. And as a result, we were able to get enough money to pay for salaries. So in the telecenter activities, on top of the computer training, we also have had a graduation. People get a certificate from Makerere University, and this is one of the first graduations. The lecturers came from Kampala. We have tourists hanging out with community members as they tell people that they're safe in Uganda and they've tracked the gorillas and they're excited to be here. And we also get school kids coming to watch DSTV. We had the Queen of Buganda, the first queen to track gorillas, mountain gorillas, coming to launch the center in 2005. She came with her parents, and it was a very grand occasion. We had over 1,000 people coming to this ceremony. The telecenter has received recognition by CNN, BBC Go Digital, and as the winner in the World Summit Award. And Lawrence also got a Stanford Digital Vision Fellowship. And we've also received international recognition for this approach of linking Uganda's wildlife management and rural public health programs to create common resources to benefit both people and animals from Ashoka. Ashoka supports people who've started non-profits. And we also got an award from the Uganda government for outstanding contribution to tourism development and empowerment of women in Uganda, together with another Ashoka fellow. Seed Magazine has also written about our work. And Scow Foundation, which is a Ugandan-based organization, gave us some money. And also San Diego Zoo also gave us an award, which Jeff just talked about. And I think one of our main strategies for sustaining all our efforts is we try and work with multidisciplinary teams. of grassroots practitioners to find mutually beneficial solutions. We work with the government workers and other grassroots practitioners by building their capacity, and we empower the target communities through model change agents such as the community volunteers that we work with to spearhead their approach in their community, and the Hugo team. And we also set up telecenter models in protected areas with linkages to community enterprises and ecotourism. Some of our future plans is to make locally relevant videos, and we want to partner with INSAF, International Conservation and Education Fund, in English, French, Swahili. We want to expand the tests, and right now we've just got some PCR machines from Colgate University, so we can also look at bacteria on site. At the moment, we're only looking at parasites and protozoa. And we want to use databases to link GIS. So we're actually going to train these community health volunteers to use GPS so we can get more information. And we want to scale up the concept to other countries where these issues are very necessary and affecting them, such as DRC, where you have gorillas mixing with people and livestock. We want to acknowledge very many people who've helped us all through. The list is very great, and without them we wouldn't have been able to get this far. And and our staff in Buindi, over there, Indigo 2. And for more information on CTPH, please visit our website at www.ctph.org. Thank you.
Well, thank you so much. I have the honor of closing the talks this afternoon, and Gladys and Steve they just have amazing programs, and every time I see Gladys talk, I'm just inspired. So it's really exciting to hear about what Conservation Through Public Health is doing. And what I'm going to do now is shift you a little bit south and a little bit east into the country of Tanzania to a drier landscape known as the Ruaha ecosystem. And this is a unique project. It's a partnership between academic institutions and non-governmental organizations. It's called the Health for Animals and Livelihood Improvement Project. And we work in the Ruaha ecosystem of Tanzania. And our main goal is to these linkages again, to assess these health and economic impacts of zoonotic diseases and water scarcity on human, animal, and wildlife populations in the Ruaha ecosystem in Tanzania. We are supported by the Global Livestock Collaborative Research Support Program, which receives their support from USAID. And we are a big collaborative project, with the lead institution being UC Davis. We work very closely with our partner on the ground, Wildlife Conservation Society, Ruaha Program, and with the veterinary school in Tanzania, Sokoine University, and also University of Vermont. I'm going to give you a little bit of background about why we're working in this region. As Steve was pointing out, these approaches of how to work in conservation, we have started as a landscape approach because we have a landscape in crisis. And I'll talk to you about that, talk to you about what we're trying to do, about the linkages between animal and human health and conservation, and a little bit about our successes to date. We're a young project, we're just approaching 3 years old, not quite there yet. So I'll tell you what we've done so far and where I hope that we'll be going in the next year. The Ruaha landscape is one of Tanzania's largest protected areas. Its Ruaha National Park forms the core of this protected area with 4 game reserves and a new community-based wildlife management area at the southern border of the park. And as Steve had mentioned earlier, similar to other countries, Tanzania has started a community-based wildlife management initiative where this area bordering the park has the villages, the 21 villages that comprise this area have donated pieces of their land to be specifically wildlife habitat. And together the villages have formed an association that manages this land. And just actually about 6 months ago, they were formally approved to manage this conservation area. Ruaha is a large area. This is larger than the country of Denmark. So we're talking a significant ecosystem in Tanzania. And the Great Ruaha River, which flows from Usangu Game Reserve, which is actually now part of Ruaha National Park. It starts in the reserve, flows through the southern portion of Ruaha National Park, where heavy density wildlife areas, through some of the villages and into Mtera Reservoir. And this river is the lifeblood of this ecosystem. Why is Ruaha important? Why are we working there? Ruaha has high conservation significance. It sits at the border of the East and Southern Africa phytogeographic zone. So we have both flora and fauna representative of both areas of the country. We have one of Tanzania's largest elephant populations, and also it's one of the last strongholds for the African wild dog. But with even this high biodiversity, Ruaha is also extremely important for rural livelihoods. Ruaha has basically a larger proportion than average of what we call traditional livestock keepers, or you'll hear me refer to as pastoralists. We have a large number of pastoralists in Ruaha who are completely dependent on the natural resource base in this area. These pastoralists have less access to health care, they live further away from the village centers, and they're pretty marginalized in Tanzania. They don't have a voice in the local and village governments. And big enough, Ruaha is significant for national development. Currently, tourism comprises 17% of Tanzania's gross domestic product. But Tanzania really wants to develop what they call the Southern Circuit. For those of you who have been on the Northern Circuit, which is the Serengeti and Ngorongoro, the Southern Circuit is destined to become Ruaha, Selous, and Mikumi. And there are big plans for development because this part of the economy is growing very quickly in Tanzania. The other reason why Ruaha is significant on a national level is the river, the Great Ruaha, generates 70% of Tanzania's electricity. That river flows into the 2 hydroelectric dams, and that's a lot of power coming from this one ecosystem. So why are we working here? It's boiling down to water. It's a problem of water. So prior to 1993, the Great Ruaha River flowed year-round. The wetlands that feed the river acted like a sponge during the dry season, keeping that river flowing. But since 1993, the Great Ruaha River has been drying up for longer and longer periods each year. In 2005, for example, we had 119 days where no water flowed in this river. And this is the same spot on the river, taken after the river starts to flow in December, and during the entire period from September through about mid-December, this is what the river looked like. And this is not a good situation for people, livestock, or wildlife. What's the consequences? Why is this happening? There are intensive water diversions for agriculture at the headwaters of the Great Ruaha River. This water is being diverted out, and it's not coming back in. And the water diversions are also occurring during the dry season when the water is needed the most. The wetlands have been damaged by intensive agricultural grazing. So cattle have now been removed from the wetland areas, but the effects of years and years and years of intensive cattle grazing of these areas, the wetlands have not repaired themselves yet. So we have agricultural water diversions, after effects of environmental damage from livestock, and we have ended up with a big problem in this ecosystem. We've seen intense conflicts now between agriculturalists and livestock keepers fighting for what land is left and what water is left in the system. There's more grazing pressure as the cattle are going into smaller and smaller areas where dry season water is available. We've seen more wildlife conflicts. This is an example of something that started a few years ago. At remaining water holes, we've had poisoning incidents where organochlorines, organophosphates are dumped into the water, animals are killed and then sold as bushmeat. So this has a significant concern for human health as well as animal health. Tourism revenues. How much money is a park going to make when there's no water and the wildlife go away? Ruaha National Park is very underutilized, and the areas where the water is drying is the prime areas where the tourists go. So this is a problem. And the wildlife management area has just started. The purpose of this area is to bring tourism revenue. The wildlife are supposed to generate income for the communities, but where there's no water, there's no wildlife. So currently, the wildlife management area is making $2 per square kilometer right now, while the park is making $300. So we have a lot of potential here, but this wildlife management area won't hold together unless we have some ecosystem restoration in the area. We're also seeing less wildlife. Very simply, buffalo are declining in Ruaha. We don't know why. They're just not there. Tourism operators are reporting that they just can't find buffalo. We've seen smaller herds. And the spatial distribution of these animals is changing. Maybe they've left. Maybe there's a disease problem. We don't know. There's a big lack of information here. Along with less water, we assume that there will be a decline in water quality. Also, the national economy. For those of you who may have been in Tanzania in 2006, Tanzania had a power crisis. For 4 months out of 2006, we had a drought. Those reservoirs dried up, and Tanzania had no power for about 4 months, only in the evenings for a very limited period of time. And that brought this ecosystem to the stage and to the policymakers once the power went out in Dar es Salaam and all the other big cities in Tanzania. So this became a forefront, and that was one of the impetus for actually removing the cattle from the game reserve and changing the grazing policy in that area. But the water diversions continue, and this system hasn't repaired itself yet. Question mark, disease. Do we know? We have a great conservation partner on the ground called Wildlife Conservation Ruaha Landscape Program, and they started hearing reports of animals dying, both wildlife, also livestock, and that's what prompted us to start thinking about this issue. Does water limitation create more disease? We've seen it before. You have increased numbers of livestock bordering protected areas. You have humans, livestock, and wildlife coming together at diminishing water sources that are of poorer quality. You may increase the risk of disease transmission between all these populations. So where do we even start? That was a big question we had. And so we took an approach that is pretty common, and a lot of you have taken it, but we started saying, I can't answer the whole problem. That person can't answer. We don't have the expertise. So we form an interdisciplinary, multidisciplinary partnerships. So on our project, we have conservation ecologists, landscape ecologists, epidemiologists, human health professionals, an ecological economist, every sort of facet we could possibly think of, microbiologist, a water pathogen expert, trying to come together with different perspectives to talk about these issues that affect so many different disciplines. We started by involving stakeholders right from the beginning, and our job and what we do at the Wildlife Health Center is to use the stakeholder involvement and then to conduct applied science. So Holly is a research project, but also a capacity building project, but we do have a strong research agenda. And then we use that through the research to provide education and capacity building. So these were the results. In 2005, we had stakeholder meetings with officials from the park, local government, academia in Tanzania and both internationally, and non-governmental organizations. And all did agree that even though we had very little preliminary data, that disease was affecting this ecosystem, and that the highest priority diseases to look at were impacted by these water scarcity issues and affected human health, especially immunocompromised people, and that would adversely affect livestock productivity, but also had the potential to affect wildlife. And so for our project, for Holly, we have focused on tuberculosis, which Steve had outlined earlier, specifically the bovine form of TB, because it can affect wildlife, livestock, and people, and also brucellosis, another bacteria, the very similar transmission pathway. Again, people get it through ingestion of raw milk, of fresh milk products, undercooked meat products. And tuberculosis, we're also working with a population that has very close contact with their cattle. Some of the pastoralists will sleep in the same corral with their cattle. They're constantly surrounded by their cattle. That is their life. That is their culture. And also waterborne bacteria and parasites. So we wanted to look at who was putting what in the water and where were the pathogens coming from. So briefly, this is just sort of for reference. It's on the webcast as well. What our main goals were is to say, what is out here and who is spreading it to who, and what is the impact of water scarcity? Is that making the disease situation worse in this area? So we've decided our goals are to determine, just look at the prevalence and transmission ecology of TB and brucella and waterborne pathogens among wildlife and livestock and the pastoral communities, and look at the effects of water management on this issue. Also, we wanted to go past just health and look at economic livelihoods. How do pastoralists with sick cattle have to change their livelihood strategies? What do they have to do? Or is it an issue? Or are they far away from a water source? Then how does that impact the mom and the family and the children that have to go get that water when their regular water sources dry out? We wanted to look at all these issues to eventually sort of be able to identify and mitigate these risks whenever possible, and also to really assess what the local capacity is for disease diagnosis and strengthen and enhance that capacity. So this is sort of an integrated approach. What we've been doing for the past year and a half is just getting data, getting information, getting out into the community, testing animals. We work with hunters, because we do have hunting in the region that we're in, to get samples from wildlife that are hunted in the wildlife management area, sandwiched between the villages and the park. We work with pastoralist households, and we test their livestock, both their sheep and their goats and their cattle. We test them for TB, brucella, and also for fecal pathogens. We're sampling water sources that are used just by wildlife, water sources that are heavily impacted by villages and livestock, to look at the different disease loads over time as the river is drying, to possibly identify high risk periods when the water quality at certain places gets really, really poor. We're coupling disease data with survey data. We have a survey that has been administered to 160 households, looking at health, both human and livestock, economics, what do people sell cattle for, why do they sell cattle, which sometimes it turns out they like to sell the sick cattle, right? Because a sick cow isn't going to be an asset in your herd, so you sell it. So why are they selling cattle? What are their perspectives on disease? Why do they think they have disease in their livestock at all? And how much knowledge do they have about the transmission of certain diseases? So together, we're trying to use this data to make solid recommendations for water management and for disease prevention, and to look at both the health and economics of disease in this ecosystem that is affected by water. And this is just a brief map showing you where we've been, which is all over. The wildlife management area run by the community is this yellow strip. The park is here, and we are active in the villages, 21 villages that comprise this area. So we're interviewing households, the same households that we interview and get the economic data and the health data. We're also testing their livestock. So we have both disease data and socioeconomic data in those households. We've been testing wildlife as well, and water sources in wildlife-only areas and in livestock and people mixing areas. And this is one of the early products, as I said, we're coming into our second year, that has come out. This is a map showing where the cows are. Step number one, where are the cattle, and are they a risk to the wildlife? What we've found out is if you go from green to yellow to red, red is the highest density areas of cattle, while green being the lower density. And these red areas have a cattle density of up to 68 cattle per kilometer. So they're very dense. And as you can see, there are some very cattle-dense areas in very close proximity to the wildlife management area. And we've actually hired teenagers, secondary school leavers, to accompany the pastoralist herds on walks when they go to graze, and tracked where these cattle go. So some of these strange lines in here are what we call herd follows. They spend the day with the livestock, just taking a GPS location every time the herd stops. And what we've seen in quite a few herds is that they go in and out of the conservation areas. So they're not there all the time, but they do go there, and they go stop at watering points inside, and they come back out. So we have some mixing of these populations, which is not surprising, because the forage is much better inside the conservation area than it is in the area where all the cattle are. So what have we found out to date? We've had 2 years of testing for bovine tuberculosis, and we have discovered that it is present in the wildlife in the Ruaha ecosystem. And this changes some of our concepts about how managers might want to manage that protected area. But it's in buffalo, which are the major reservoir species for TB in that ecosystem, and we have identified it in an impala. So we don't know for sure, but there's likely been contact. We're working on trying to figure out if the strains that buffalo and impala have are the same types of tuberculosis that the livestock have in the area. And that's the connection. It's sort of who is giving it to who. But what it tells us is if we're going to practice disease control in the villages and say we're going to get rid of TB in the villages, we now likely have a wildlife reservoir. So we have to be careful about how we manage disease prevention programs. Our household surveys are yielding really interesting information. We're just starting to analyze them. We just finished them. And we've surveyed 160 households, and this is Mariam. Nguvava, and she's our socioeconomic researcher. And she has trekked by foot, by bike, by car if she's lucky, to all of these households and sat with these people and really spent time getting to know the pastoralists, getting to know what their perceptions are. We've also talked to village leaders. It's interesting to compare what village leaders think are the problems and what pastoralists think are the problems. And all this work is ongoing as part of Michel Mazozera's PhD. He's currently at the University of Vermont. So we're working on this. We've introduced new diagnostic techniques to Sokowania University, who is fastly becoming a center of excellence for both tuberculosis research and microbiology in the region. So we're excited about that. And we have a really high level of community involvement. Somebody's actually coming, talking. We're providing feedback. We talk to the pastoralists. We work with them, interpret the test results with the livestock owners present so they understand the disease and they understand how to prevent it. We're now working on follow-up with these households, trying to figure out if they're following some of the advice we're giving, if they're not, and if they're electing not to, then why? What are the decisions that are making them say, no, I know that cow has TB, but I'm not going to sell it, I'm not going to cull it, I'm keeping it in the herd, but then why? Why are they taking that risk? So those are some of the questions we're interested in. We're very active in training and capacity building, being part of a university program. We have 2 master's students, both Tanzanian, getting their education in Tanzania, 1 PhD student who was Rwandan, getting his education in the U.S., and we've had 3 externs, all 3 of them African nationals. So we are really committed to this work, and this is one of our master's students, Annette Kitambi, and she's working on water quality issues. So she's working with a local government technician, and they're reading a water quality test. So anytime we can, we're trying to pull in interested people. We've trained community game scouts how to reduce their own risk of disease contamination because they go into the field with the hunters. They often butcher the carcasses. The conditions are not sanitary, and they're being put at a risk. So we teach them. They know how to recognize the diseases. They already know. That knowledge is there. So we just are trying to show them simple measures to reduce their own personal risk. And we also hire community game scouts as field assistants. In the lab, we're doing the same thing, more training and capacity building. This is Dr. Valtrina Miller from the University of California, Davis. Her expertise is in water microbiology and protozoal pathogen work. She just finished a visit to Tanzania, training the Sokowania University laboratory staff. So now they are doing more advanced biochemical tests, looking for pathogens like Salmonella and Shigella and Vibrio in the water sources. And then we're going to actually source them out and see if we have the bad bacteria with some pathogenic factors or not so bad there. And again, this is Jonas Vitangiri. He's working on TB culture. And so where are we going from here? We're a 2-year project. We're just starting to get results. If I come back in a year or 2, I will have some really great information for you. I know I will. But right now, what we want to do is we're gathering this information and we're starting to look ahead and say, okay, where in the landscape is the TB? Are houses that are close to wildlife more affected? Are they not more affected? Are houses that are more water limited more affected? What are the relationships? And the next question that we're starting to get to is the human factor. As Gladys has aptly pointed out, they've started a community TB treatment program as part of Conservation Through Public Health. It's something we really want to do, and we've been talking with the National Institute for Medical Research, which works with the National Tuberculosis and Leprosy Foundation in Tanzania. And they're very interested, especially in the pastoralist communities, because very little has been done to look at the effectiveness of community DOTS, the daily observed treatment programs, in nomadic communities. Would that sort of a system work? What are going to be the things we need to change to make it work? And along with that, we can get data looking at how much TB is in the pastoralist households. We know what's in their cattle. We know what's in the wildlife. We still yet don't know what's in the people. So that's one of our next steps. We're also looking into sustainable biosand filtration technology at households. So actually making sand filters to filter bacteria and protozoal out of the water. They're pretty reasonably priced, and it could be set up as a micro enterprise. So that's one of the things we're looking at as well. We're partnering with another GL CRISP project to investigate whether or not we could start that initiative in our region. and providing feedback. In August, we're going to start community workshops, starting to present some of the data and get some extra opinions from people about what they think, as well as filling in holes in our data. So we'll do both smaller groups, women's groups, and larger village workshops, starting to get that outreach component going. We're starting radio shows. We had a radio show on water quality, and we're hopefully gearing up for World Rabies Day in September to maybe do a show also about rabies. But again, starting to get into the community network and starting to formalize how we're going to move our research into education and intervention efforts. And eventually, we'll move it into policy. So that is one of our goals. It's one of our bigger goals is how does all this relate? Is there an amount of water in the Great Ruaha that if you kept that river flowing would reduce the disease burden in the river? We don't know, but maybe that's a point we can get to with our data, and that's what we're trying to get to. Another argument to make interventions to keep the water flowing in this system, and that's pretty critical. So again, this is the value of One Health. I think through all these presentations, it's probably become clear, but these problems are complicated. We need multidisciplinary teams. We need long-term funding because these issues don't tease out in 1 or 2 years. We need sustainable funding and efforts to make these issues work. And Ruaha is at a crux. It can be a model for how One Health works and how these complex problems can be solved, or it can be a casualty. And we're right at that point where we don't know what's going to happen with this ecosystem. So we're going to push forward and keep trying to find solutions and hope that we're going to be a model. And there is a website reference and also a handout outside with a more in-depth article about the Holly Project. And this is, again, we're from the Wildlife Health Center at UC Davis. And also GL Crisp, our primary sponsor, is based out of UC Davis as well. And just a brief thanks to have me here. I'm going to close it quick because everybody's getting tired. And a thank you to my team in Tanzania who go out there every day by foot, by car, get broken down in the cars, all those fun things. And how they are really persistent and they work really hard to make this project happen. Thank you.
You guys come up here and so that you can answer with the microphones. Thank you all, three of you, very, very much. You've given us a tremendous amount to think about and to process. Why don't we have a Q&A, and we can start with Tim Resch right up here. And have some from our web viewers as well to share. But why don't we start with Tim, please?
Yeah. Jim Resch, USAID Bureau for Africa. Excellent presentation, and shows the kind of the complexity of interrelationships between wildlife, domestic animals, human health, and the environment, which is a really complex situation in a steady state climate situation. And Deana makes a good demonstration of the impact of less water. And so the models show a hotter Africa and many parts of Africa, a drier Africa, as well as greater periodicity of kind of when do the rains come and which rains come. So in the scenario planning associated with dealing with all of these interactions, how does the additional complexity of one, global climate change, and I think Deanna's presentation also demonstrates the importance of policy change with the policy change associated with water drawdowns and cattle in the park, and so we could kind of put all those things together, but there's all additional externalities that further complicate the scenario planning or the actions. And so, how do you plan for all of these contingencies? Steve would do it the best, of course.
Yeah, I'll just make a brief comment and hand it to Steve. I completely agree. It's something, when we think of Holly and we think of this water drying, although it's from a different cause, it is a great example of what could happen to a system if climate change causes drought. What we're seeing in Ruaha right now are the extremes. So we had extreme drought through 2006, and then in 2007, the rains came and we had flooding everywhere. In fact, our whole team had to evacuate our field camp, and we were stuck in the city for a very long time. But that caused a whole new set of health problems as people's latrines were overrun with water. We had lots of diarrhea in the community, and following hot on the heels, we had a Rift Valley fever outbreak. So, you start to throw some of the predictability to the wind, but what we've seen is this variability and unpredictability will heighten the possibility of health catastrophes.
Yeah, I would just add, when we have changes due to climate variations, vector distributions alone changing can be a huge problem. You're talking about mosquito-borne diseases, tsetse fly-borne diseases, tick-borne diseases. I won't even pretend that the scenario process leads to, an all-knowing situation. But what it does do, we're in the Limpopo, for example, through support from both the MacArthur Foundation and the Rockefeller Foundation, we're doing scenario planning exercises at the community level and also at higher governmental levels, and it's all part of preparing for these types of uncertainties. But it sure makes this very, very tricky. So all the issues that Deana went over in terms of the direct impacts of water on livestock and on health, you throw on top of that the spin-off effects related to vector-borne diseases that can change across the whole landscape. All of these systems tend to be driven by hydrology. So we're building sort of the climate change issue into all of our programs, but I personally find it quite challenging. It's really made things that much more complex, as if it wasn't complex enough already. But as long as, I think it's important that everybody is at least acknowledging that they have to start thinking about the unpredictability of some of the things that could happen down the road. But I've found it with government partners, they're finding it helpful to at least think about these different scenarios in terms of their future planning.
Okay. We received one question from a web viewer, and I'll pose this for Steve, from Steve Hearn from the Army Environmental Policy Institute. It reads the Botswana, I think picking up on your Botswana experience. Botswana Defense Force has reportedly employed its professional army successfully to secure its wildlife resources. Given the assets available to many national armies on the continent, what role do you see, if any, playing in the ecosystem and human health protection? How receptive would this assistance be to NGOs, IGOs, local and regional institutions, given past history and relationships? And do you see a role for the U.S. military? I think they're probably thinking in the terms of the Africa Command, given its assets and competencies.
It sounds like we should have a conference just on that very important question.
We've had a couple of them, yeah. But
the Botswana situation is very unique. General Kama, who's now president, when I was there, he was commander of the armed forces. He's an ardent conservationist. He's on the board, or has been on the board of Conservation International. And the Botswana Defense Force is extremely well-resourced and trained. And so I work with them quite closely on everything from anti-poaching to dealing with problem animals. We would have to catch a leopard in a village, and General Kama would send one of his helicopters to move me from A to B. It was that kind of relationship. But I think that's unusual. There are certainly many countries where the military is not necessarily seen as a benevolent factor, both the domestic military as well as the U.S. military. And we've had, I don't know if Shannon Beebe is here, we've talked a little bit about AFRICOM and the challenges of partnering in this current geopolitical environment. I think as maybe our foreign policy takes account of more soft power tools, if I can say that, there may be indeed opportunities for technology transfer and training so that military, the military can provide support for these things. But I think it really depends on the place. I don't think there's a general rule. I think Botswana really, in many ways, is an exceptional country. And the BDF has done a very interesting job in conservation and helping people. Uh-huh.
Gladys, in your presentation, you mentioned the change with the role of the military in and around the park. Would you like to elaborate on that role in terms of either the opportunities or the challenges that has presented for you in your work, in the case that you know best?
Regarding the military in Burundi, obviously they were needed because of the insecurity in the area. And I think the benefit of having them around is even if you hear that there's some rebel activity close by, you know that the military is there, and they always send extra military if necessary. But the problem is that since the military came and started living in Buhoma, this area that was relatively, I would call innocent, is now becoming very, for example, the HIV rates have increased in the areas because the military, of course, prostitution has gone up because of the military. They throw a lot of rubbish around the park. And there's many issues with them. In fact, during the TB research, when I was at NC State, I tested some of the military as well. They were part of the people who we tested because they actually walk up to the gorillas with the tourists. So I think the challenges we have now is the military needs to be part and parcel of the health programs that we're setting up around the park, and they really need to be educated about the dangers of some of the habits that they have. So it's quite a big challenge having that group of stakeholders within the park. But then at the same time, they're needed for security.
Okay. Yes, please, sir.
Thank you for your next presentation. My name is Julius from Tanzania, and currently I'm doing my internship with ABCG, and I'm a medical doctor by profession. I would like to pose a question to Deana. What is the... I know that the government, when I was coming to United States, that they were asked people to move away from that area, particularly the pastoralists. And I don't know how much is the cattle left there and how many people. And also, what is your focus on HIV/AIDS? Because I know that Iringa and Mbeya and Morogoro, it's the prevalence of HIV/AIDS is quite high in Tanzania.
Yes. Sure. So in addressing the first part of your question regarding the cattle movements, the government did evict the pastoralists from the Usangu Game Reserve before it became gazetted as Ruaha National Park. There were tens of thousands of cattle in that area, and that did happen during 2007. The controversy erupted over that move because it was very heavy-handed. Pastoralists were not given any land tenure rights or enough time to move out of the area, and arrangements logistically weren't handled very well. So what occurred was a mass exodus of people with nowhere to go. There was land theoretically set aside for them further south, but what we were hearing on the ground was that there were toxic plants in that area, the cattle weren't going to do well there, and the operation was handled by the Tanzanian military. So this brought together a lot of issues about pastoralist rights, land tenure rights in Tanzania, and it brought a complication because the Usangu Game Reserve area is a well-known tuberculosis hotspot. So what has essentially happened, it's good for conservation because the cattle have been removed from the wetland, and the wetland itself now is having time to restore. We are seeing wildlife return to the Usangu Plains area. The swamp is slowly getting bigger. It's not restored enough that the river is flowing. We still have to deal with the diversion driver that is occurring even upstream from the swamp. But what has happened is an examination of, okay, we took cattle for conservation purpose, as Steve was saying, out of a protected area. But now we have cattle from a tuberculosis hotspot that have gone everywhere. So have we then made the TB problem worse because people are settling? They're not all going to the land area that's been designated for them. They're settling along the way. And that is causing conflict within local communities, especially our area, because the Sukuma pastoralists were coming through our area and trying to settle. But our region has so many pastoralists already and so many cattle that there were actually efforts to find those people, round them up, and get them out of the village areas. So you have a lot of people with a lot of cattle with nowhere to go. And it ended up being a pretty serious situation. There was a government commission, which Professor Kozwala, one of our lead investigators for the Holly Project, participated on to look at how that situation was handled and what could have been done differently. For many, many years, WCS Ruaha program had been advocating a slower removal from the park associated with land tenure, associated with a bigger program, and that didn't happen. So it's been quite controversial, that removal from the park. We've seen benefits, but we don't know. There could be some repercussions down the road as we continue testing for TB in these areas. And then the second part of your question regarding HIV/AIDS. At this point in time, we do not have a direct intervention program. What we'd like to do is partner with the National Institute of Medical Research, because you're totally correct. In Mbeya, Iringa, those are HIV hotspots. And that is one of our concerns, is that we don't know in the pastoralist community what the status of that is. We're hoping that by instituting a community DOTS program in those areas, we'll also start HIV testing along with community DOTS. So in the programs that we were talking about in Tanzania, that testing would be required of people that went on to DOTS therapy, because it's going to affect their, possibly could affect their therapeutic outcome. So we're really hoping to get that effort up and running and start looking at that relationship.
Just to briefly mention, I mean, the resettlement issues really reverberate across many of these landscapes, and they're always hugely controversial and often very poorly handled. For those of you who are particularly interested, we just supported, the HEAD program supported an evaluation of government decision-making regarding the Usango resettlement. And I haven't even put it in the public domain yet, but I'm happy if you send me an email. It was done through the Tanzanian Natural Resource Forum, TNRF, and I think it's actually on their website this week. But it just came out, and it's really looking at what really happened politically there, because it was really quite complicated.
Yes, sir. Please.
Hussein Mansour from Egyptian Embassy. I would like to thank the panel for the very informative presentations you gave us today. In fact, I want Steve to comment on the issue of the avian flu, as it is a great example for human, animal, and ecosystem health problem. And there is a lot of controversy about the role of wild birds. Are they a victim or they are the cause of the avian flu? And I'm not sure that there is any clear plan now to how to prevent them or to from transferring the virus, and how to protect them from getting the disease, because we may lose them too. And right now, because there is intensive commercial flux has been affected in Africa and Asia, and Egypt is one of those countries, they may affect now the wild birds from the commercial birds. It's not, it's going the other way now, actually, and they have more potential to travel with no borders, with no visa, from place to place, and just to spread the virus. Then we need to protect them, and to protect ourselves, and to protect the animals, domestic animal as well. Thank you.
I'll say a few things, and I know we have a few experts on this in the room that I'll try and bring to the fore. Egypt is actually one of the countries that's collaborating on the GAINS, the Global Avian Influenza Network for Surveillance, and this program was started to answer those questions. What is the role of wild birds? And it's a mixed bag. Certainly, some of the movements around Europe seem to have involved wild birds. Most of the cases that have been documented around the world have been involving the movements of poultry, legally and illegally. There's a lot of poultry smuggling, movements of day-old chicks out of China and Thailand was a big problem. For the most part, most of the wild birds that we and our colleagues have seen, if they get the virus, they tend to get quite sick and die and don't move very far. There are probably some exceptions to that. And so really the emphasis right now, and we're partnering very closely with FAO on this, is to emphasize biosecurity, to prevent movements in both directions. When you look at Egypt and Sudan, you've got some very important flyways there, and so we are concerned about what you were saying, potentially wild birds helping to spread it. But so far, poultry movements have predominated the movement of this disease around the world. I don't know, Christine Smith is here from the GAINS program, and if Gavin McGregor-Skinner's still in the room, he might want to say something about Egypt as well. I don't know. Christine, you want to?
Sorry. The GAINS programs really try to answer those exact questions that you posed. And just basically to reiterate what Steve has said is that we have found those few exceptions where wild birds have moved the virus and survived long enough to perform their migrations and take the virus, even in some instances, to a country where we haven't seen the virus before. However, those instances, which seem to right now be the exceptions, leading to outbreak scenarios in people and in poultry, we haven't seen that play out. So most of the major outbreaks that we've seen in new locations have been because of poultry movement. So, and one of the areas that we're also trying to focus on as well, in addition to wild bird migrations, is the wildlife trade, the illegal wildlife trade, because that seems to be more of a risk, because then you have not only these wild birds with the virus that are shedding it, but they're in close quarters with other species that haven't seen this virus yet, with poultry and with people. So that's really where we fear the risk lies. So far, we really haven't seen the wild bird movements leading to outbreaks cause a major issue. And in a lot of the instances where we have seen it in wild birds and they've carried it and even infected other wild birds, often they die. And so we haven't really seen it sustained that we've identified in wildlife populations to this point. So
I spent so little time on GAINS. The GAINS project, if you go to gains.org, it's a publicly accessible database, and the whole point is to be able to start to put data in the public domain so you can actually look at where wild birds have been sampled, anywhere in the world, and overlay it with poultry data, overlay it with human health outbreaks. And the whole idea is to give the epidemiological community the chance to answer these questions. Because up until this program, I'm not aware of at least a wildlife health surveillance program that was in the public domain. People tended to do this research and hoard the data until it was published. And we've taken quite the opposite approach. We think this is a global public good, and so we've tried, all of our partners have to put their data in this system. And so it's for ministries of agriculture and ministries of public health to be able to look and say, all right, chronologically, this happened in South Korea. There were some people we actually had telemetry devices on birds moving from Mongolia, whooper swans, which was an AI hotspot at the time, down through the Korean peninsula. And some people looked at this data on the web and said, the whooper swans, they brought the disease. But we actually had the data to show temporally that the whooper swans arrived after the disease had broken out in poultry. And in fact, they were at risk because we had tested them and they were negative. So that type of project is really helping to answer these questions.
That's right. Yes, Jim?
My name is James Rocco, and I'm, for these purposes, president of the Trust for Lead Poisoning Prevention. About a decade and a half ago, we did a study, slightly outdated now, as you might imagine, but the main results are probably the same, where we collected data on lead poisoning throughout the world. And we found that there were a number of studies on the effect of lead on wildlife. For example, looking at Africa, trunk flaccidity in elephants around Lake Victoria. So my question, and during your presentations, you did mention a number of examples of what we might call pollution or environmental disease as opposed to infectious disease, for example, poisonings, if you will, at the water hole, possible effects of pesticides and so forth. So my question is, I wonder if it might make sense to have in your data collection and in your studies and in your programs a little bit of emphasis on the systematic collection of data regarding environmental sources of exposure that might exist and possible linkages and approaches to addressing them. Of course, I'm not criticizing you. I'm sure you're already doing it, but it seems to me maybe a little more systematic incorporation in community assessments of problems and so forth could be very helpful in identifying pollution sources and control options.
I can just address that a little bit. I completely agree. It's one of the things that sort of, comes up in casual conversation. We hear a report. 2 months later, we're hearing something else. So we're trying to follow up on some of those with our partner, the WCS Ruaha Landscape Program. We're starting to map these suspected areas of toxicity, and we have found a young ecotoxicologist at Sokoine University who is doing great bioindicator work in catfish. So in our system, Mtera Reservoir, the Great Ruaha feeds into that reservoir, but these catfish are pretty ubiquitous around Tanzania. So he's starting to use bioindicators, which this technology is a little more available in Tanzania rather than some of the other technologies for ecotoxicology. So we're trying to partner with him to look at some issues in the Ruaha landscape, and I think it's something that needs more attention, that we're trying to sort of identify partners to do some of that work. But definitely in our data, there's room to incorporate some more questions about that we don't have now.
Yeah, I mean, in a number of our programs, we are looking at those issues, and even in Tanzania, things like artisanal gold mining and the mercury problems are huge. And part of it comes down to something I think Gladys alluded to. Part of it is funding streams are fairly targeted in what you're allowed to do with different pots of money. So if you get infectious disease money, you can't look at ecotox, and if you get ecotox money, and vice versa. So we all struggle with that a bit, but know that these issues are part and parcel, particularly when you're talking about water. and both in terms of monitoring people and wildlife. We do a lot with birds in terms of looking at feathers and doing all kinds of analyses in terms of where they've come from and what they've been exposed to and things like that.
Okay, well, we've come to the end of our period, although it seems to me that there are an awful lot more questions and discussion that we could have. I'll urge you all to, well, grab them now as we end in terms of the discussion and continue your conversations, but also yourself and your colleagues direct them to the Wilson Center website, to the respective websites you've heard from our three presenters. The video and the slides and a summary will be available on the Wilson Center site. We hope that you all can help us continue and advance this discussion that is bringing these different communities together that don't often have the opportunity to talk. We try to make a point of doing that here at the Wilson Center, getting folks who aren't in the room often together to have these conversations, because as we've seen, so many different connections and so many complexities, and perhaps if we can continue to demonstrate the importance of that, some of these funding mechanisms that help you get your important work done will adjust to that flexibility as well, particularly as we can see these real successes